Hey guys, so this is chapter 16, which is actually the first part of the immune system. And to be honest with you, this is all a review for you because you've already had anatomy and physiology, which means you've already studied the immune system. This is our immune system and how it responds to microbes being present. So essentially all of this you already know, and it should be a really good refresher for you just to kind of pick up on some of those quick tidbits about the immune system and then move forward. So 16 and 17 really honestly should be one chapter. I know in anatomy and physiology we do it all in one chapter, so I'm not sure why they break it down here. But they do break it down based upon the different types of immunity you have. So you have the innate immunity, which is that you're born with, and then you have the adaptive immunity. So we're going to start off here on chapter 16 and talk about that immunity that you are born with. It does not have any type of specificity to it. It's one of those defense mechanisms that you have against any old pathogen that you may come into contact with. You have these when you are born. You're actually coated with maternal immunoglobulins in the beginning while you're building up your immune system. And then afterwards, essentially what you do is, those first 6 months as you're coming into contact with things, you're able to develop your own and then take over from there. This particular type of immunity doesn't really recall any infections. It has nothing to do with antibodies. That's all going to be in the adaptive immunity. This is simply your early warning system that something in the body maybe isn't quite correct. So with the innate immunity, this is our first and second line defenses. And then in chapter 17, we're going to take a look at T cells, we're going to take a look at B cells, and we're going to take a look at antibodies, which are being made in response to antigen. You make antibodies in response to antigen. Your body is constantly communicating with itself. We always send out chemical signals alerting the body, knowing when we need an immune type of response. We know the duration and the strength of the immunity based upon these signals that are being sent out. And we actually do call other cells to the area when we know that we do need some type of defenders to be present. Some of the things that we are born with that are already present, kind of a natural thing that are these first lines of defense is number one, just your skin. Remember, your skin is a little bit acidic. It does have a very protective protein within it called keratin, and then you slough your skin off. Your skin today is not the same skin that you're going to see in 3 months, because remember, the layers of the epidermis make their way from the bottom to the top where you shed that off. Well, when you shed that off, you also remove the bacteria that is on it. You have mucous membranes. Well, you didn't take me with in A&P, but if you would have taken me in anatomy and physiology, you would know one of my slogans is snot is good. You need it. I have a t-shirt that says it. Someone made it for me. Snot is good. I love it. You have to have mucus because mucus traps those microbes. And then you have cilia around those microbes, around those mucus that help to beat and move those away from your lungs, for an example. You have constant flow of secretions like in the eye, in the mouth, in the urinary tract, in the vagina. And what that does is it helps to move these microbes hopefully out of the body so that they can't actually colonize. You have things like pH differences in the stomach. Not a lot of things can pass through the stomach. Now, granted, we've talked about some that can, but we do know that the stomach content being down at a pH of somewhere around 1.5 to 2, give or take, essentially microbes can't survive in that. And so if you eat something, hopefully we destroy that automatically. We also know that in our secretions, like in our tears and our saliva and in fluids, there's lysozyme, which is an enzyme that helps to break down microbes. We know that normal microbiota are present on our body They're supposed to be there. They help us fight off those transient microbes just in case they do come into contact and want to try and inhabit our body. We also know that blood cells play a role. You guys remember talking about what erythrocytes do. Red blood cells carry oxygen and carbon dioxide. Platelets are involved in the coagulation. But it's the white blood cells that I want to take a look at, because a lot of times, if I can know a blood cell count of a patient and be able to differentiate, okay, what's elevated? Are the neutrophils elevated? Are the basophils elevated? Are the macrophages elevated? That gives me a very large tip-off for what these particular patients are potentially going to be diagnosed with. For example, this is a look at a white blood cell count, and they've taken a percentage to show you the normal values of all of these cells. If I have a patient who comes in and their neutrophil count is the only thing elevated, automatically I know two things. Number one, it's most likely bacterial, because neutrophils have the nickname of being our bacteria slayers. And number two, this is a very early infection. We have caught this early on, because if neutrophils are the only thing that is going to be out of range, those are the first cells that are sent out when we get these types of infections. So if it had been a more chronic type of illness, we would see other things elevated than just the neutrophils. Now let's say you have a patient that comes in and their basophils are elevated. Well, basophils are involved in inflammatory types of process, so that could tip me off that maybe there's something going on there. We also have eosinophils. If you have a patient who comes in with an eosinophil count, I'm thinking one of two things. Number one, it's an allergic reaction. You can see allergic reactions. If you've ever seen someone that's allergic to bee stings or peanuts or something that they come into contact with, it's almost instantaneous that they start swelling up, or they start having respiratory distress, or some sign or symptom starts manifesting itself. So if I have a patient who's sitting in front of me and their eosinophil count is elevated and they're not having an allergic response, that automatically points me in the direction of a parasitic worm infection, because these are the cells that are going to be responsible to trying to break down parasitic walls. Monocytes elevated. Monocytes are immature macrophages. And so if I have lots of monocytes, that means I have lots of macrophages, which tells me two things. Number one, it's probably bacterial. And number two, you've had this for a little while, because now neutrophils would be the number one responder, and these are your big responders that come in after we've had this infection for at least a couple of days. So this is not something that's going to be brand new infection. And then lastly is our lymphocytes, and our lymphocytes are our T cells and our B cells, and if those are elevated, that tells us that there's some sort of immune type of response that is going on at the level of production of antibodies. When you look at a phagocyte, it's very interesting to see these macrophages actually engulf a bacteria, but the word phago means eat and the word cyte means cell, so literally it's a cell that eats other things, and the process that it goes through is simply to bring in the bacteria, and once inside, fuse it with the digestive enzyme, which is lysosome, and that lysosome then starts to break down and destroy whatever bacteria is inside it, and then what's ever left is essentially no longer any risk to the host cell. Problem with this is that there are several microbes that actually can either live in a phagosome, it can kill the phagocyte, it can escape before the lysosome has time to work. Some of them essentially just don't allow for the lysozyme to fuse with that particular phagosome, and therefore the lysozyme never can get inside to start digesting it. So even though we have these cells in place that we're born with, that are supposed to be there helping us, that's not a guarantee that it's going to kill everything. One of the natural processes that your body goes through is inflammation. Inflammatory processes lead to tissue repair. And if you have damage to tissue, you absolutely have to be able to repair that. And the reason for inflammation is essentially so that you don't get infection. That's what we're trying to prevent. So yes, there may be some redness, there may be some swelling, it may hurt. If you injure tissue, there's some nerves there and it does hurt. But the first thing that we find with inflammation is that we're going to release out chemical signals that are actually telling our body that there is injury and that we need to call in other cells to this area. So the blood vessels are going to dilate, because when you dilate blood vessels, what happens to blood flow? It increases. And if I speed up blood flow, that means I bring in more cells. And all of the white blood cells, all of those phagocytes, all those neutrophils, all of these need to come to that site and actually enter up into the tissues to clean that area up. This is a look at some of the chemicals that originally are being released. These are all vasodilators that essentially help to open up those blood vessels so that we can bring in the appropriate cells. So here's a look at inflammation. You can see on here that the epidermis has been damaged down all the way through, even some into the epidermis. Looks like this patient got stabbed, and obviously most of the time if you're going to be stabbed, it's not a sterile knife. It's going to have microbes on it. So we have microbes that have entered into the area. Automatically, chemicals are going to send out. Automatically, blood vessels are going to start dilating around the injured area. Immediately, we do see that these phagocytes and white blood cells are actually going to adhere themselves to the sides of the vessels, and those vessels are going to pull apart ever so slightly so that those phagocytes can migrate up into the tissue levels. Now, normally that doesn't happen. There's a signal that tells those vessels to do that. And those cells, what's up inside, can then start taking care of the microbes, any debrisement that may be there, so that we can hopefully heal this wound and fix those epidermal layers without any risk of infection. Another thing that your body naturally does is when you get sick, it turns up the temperature a little bit. I'm not talking about a fever that's up at 105, but I'm talking about a low-grade fever. The reason why is because whenever interleukin-1 is being released into the body, the hypothalamus turns up the temperature a little bit. You guys know that microbes don't actually like temperature changes. They don't like it when the temperature goes up a little bit. So hopefully what we're trying to do essentially is maybe discourage the microbes from wanting to come in. But we also know that things go faster at higher temperatures. Heart rate is elevated, blood pressure is elevated, and so what we find is that the blood is actually pumping faster, which means that cells are getting to areas where they need to a little bit quicker, so that we can then hopefully try and get these cleaned out before they can settle in and cause major damage. You do have to be careful with fevers, particularly in elderly and in newborns. We do find that dehydration will happen very quickly. So any extended period of fever is not something that you want to mess with, and I'm not saying that that's something that is normal by any means. Also, after a while, fever can actually lead to an acidosis. If you think back to when you were talking about changes or imbalances in pH, and then it does cause a quickened heartbeat, and the more you get dehydrated, the faster that heart beats, which kind of all goes as a disadvantage to us. A big thing that we have, and it is a very big process for us, and you will have to know this frontwards and backwards. I'm telling you now, know your complement system, because this is the way that our body is able really to defend ourselves from early on. This is one of the biggest aspects of the innate immunity, and what we find is that they're proteins. They're made inside of the liver and they circulate in the blood and in the tissue, but the problem is they circulate inactive. which means that in order for them to work and do their job for us, we have to activate them. I'm going to first talk about the most important complement that we have. Complement are listed in numbers. So we have C1, complement 1, C2, complement 2, all the way through C9. The most important one that you have out of those are C3. C3 is vital when it comes to complement. And the reason why is because what happens when complement 3 is activated. If you take a look at this picture on your screen, this is what happens after C3 gets activated, and then I'll come back and talk about its activation. When C3 gets activated, it splits, just like breaking in parts, into C3b and C3a. C3b automatically then activates C5. And what happens when C5 gets activated is it breaks into C5b and C5a. C5b combines with C6, C7, C8, and C9 to give us this huge complex called the membrane attack complex. The membrane attack complex, or what we nickname the MAC, M-A-C, is a very, very large bacterial killer. When it comes into contact with bacteria, it will uptake those and it will destroy it. C5a also has the job of releasing a chemical signal that calls out and attracts other phagocytes, so we're able to bring in other cells to the area. C5a and C3a combine together to work on mast cells, which release histamine, which is huge in the process of inflammation. When you have a patient who is in anaphylactic shock, the reason why is because they have such a large inflammatory process that has started. And if you draw their blood, they will be extremely high of C3a and C5a complement. Those are actually called the anaphylactics. And then lastly, if you take a look at C3b, C3b does something called opsonization. And what that is C3b will actually coat itself around the microbe and enhance phagocytosis. Macrophages are going to uptake these microbes anyway. But it's sort of like if I went home to David, who is a big meat eater, and I said, okay, you can either have this filet mignon or you can have this piece of bologna. He can eat either one of them. They're both meat-ish. But he's going to pick the filet just because he knows it tastes better and he likes it more. So these microbes that are coated with this C3b, they're probably going to be uptaken anyway. But what happens is these macrophages, sort of like a shark in a feeding frenzy, swarm to that microbe very quickly and then hopefully destroy it, enhancing our phagocytosis. So all of those things happen thanks to the activation of C3. Patients who are C3 deficient, it's not that they don't have an immune system at all, but they do lack these other processes, and that can be something that can be detrimental to those patients. This is a look at opsonization and the membrane attack complex. This is a look at that histamine being released from the mast cell thanks to C5a and C3a, and then you can also see C5a sending out that signal calling in other macrophages. So the question is then, if C3 is so important, how do I activate it? And the answer to that is there's 3 different ways. 99% of the time we do this. It's called the classical pathway. And as long as your body is working the way that it should be working, this is going to happen. It may not make sense to you guys because when I show you the other pathways, they seem much easier. But easy isn't always right. This is correct because you make antibodies. You want your body to make antibodies. It's very, very important. So the classical pathway happens when an antibody attaches to an antigen. Remember, antigens are foreign. They're found on things like microbes. Well, when the antibody and antigen come together, that automatically activates C1. When C1 get activated, that automatically activates C2 by splitting that into C2b and C2a, and C4 by splitting that into C4b and C4a. C2a and C4b find each other and come together and automatically activate C3. Once C3 is activated, you then know what happens. So this classical pathway is what we are going to be most of the time doing. But what if you have a problem? This is one of the issues with Ryan, my Ryan. She makes antibodies, but they don't work. What's the point of making an antibody if it's not going to function? Well, there's little to none. And so what happens if antibody and antigen are the only way to activate this is you would lose all of that for patients who have antibody issues. So there are alternative pathways. We don't utilize them though as often because we want to make antibodies. Here's a look at and it's called the alternative pathway because it's an alternative pathway. Go figure. Doesn't have anything to do with antibodies. Instead, it actually has to deal with proteins that are found on the complement and the microbe itself. So there are factors that are found on the surface of the C3, and they're going to combine with a lipid carbohydrate mixture on the microbe. So on C3, there are these factors: B as in boy, D as in dog, P as in Paul. And these are going to bind to this lipid carbohydrate complex on the microbe and automatically activate C3. So again, that sounds so much easier, but you need antibodies to be produced. The last one is called the lectin pathway. This one was recently discovered, as recent as enough when I was in med school. They were still trying to decide. We talked about this, but it was not yet a pathway. But what happens is this. So whenever a macrophage uptakes a foreign object like a bacteria or a virus, then that macrophage is going to start breaking that down with the lysosome. But it also releases a signal that jumps into the bloodstream and travels to the liver. So the macrophage releases this signal, gets into the bloodstream, and goes and stimulates the liver. And what it tells the liver to do is to produce an enzyme called lectin. Lectin can bind to a very specific part of a microbe, and it binds to a carbohydrate and sugar complex. So when this lectin binds, that automatically activates C2 by splitting it into C2b and C2a, and C4 by splitting that into C4b and C4a. C2a and C4b find each other and combine, and in turn activate C3. So this pathway we do know is happening. Again, it's not something that's going to be the most common way to activate C3, but at least there are 2 additional pathways that we know of that don't involve antibodies and can help to activate C3 if something is going on at the level of making antibodies. We do know that complement is not the cure-all. It's not going to get rid of everything, because there's plenty of microbes that actually can prevent formation. Some of them can prevent activation. Some of them can break down certain little parts like C5a or C3b. And so it's not something that can be used for everything. We also know that bacteria are not the only things that you come into contact with. There are also viruses, and I've already told you that the immune system has a really big problem finding viruses and then killing them. Our biggest defense that we have for viruses are called interferons, and there's 3 types of interferons: alpha, beta, and gamma. Gamma interferons have nothing to do with viruses. Those actually are recruiting neutrophils and macrophages to come and eat up those bacteria. So gamma interferon is another bacterial aspect. But the alpha interferon and the beta interferon actually work to stop viral reproduction. It doesn't allow them to replicate. And if viruses can't replicate, that means they can't grow. And if they can't grow, eventually they will die out. And so what we see with this is alpha interferon is actually utilized synthetically. We make that in a lab and given to patients. It's been approved to give to patients with chronic types of viral infections, sort of like hepatitis. We give hepatitis patients interferon to hopefully stop some of this replication, and therefore the virus eventually die out. So with the innate immunity, we do find that you're born with it. We found that it's not something that's going to be specific. It's not something that's going to give you really an awesome immune system. It's just really an early warning sign so that your adaptive immunity can do its job and kick in. One of the things that we do find, a lot of people talk about immunity that is given in across the placenta or given in breast milk. There's actually not a lot of antibodies that are found in breast milk. There's a very small amount of them. We do say that if you wanted to have the full effect on the immune system for breast milk, you would have to at least breastfeed for 6 to 8 years. Years, not months, years. So, not a lot of people here in the United States, now a lot of people elsewhere do that, but not a lot of people here do. But I mean, this innate immunity, things in the tears, things in the saliva, things in the blood that are automatically circulating do play a role in making sure that we're staying healthy. The big role, though, against microbes is being able to be specific. Being able not only to just kill any old microbe, but hone in on one specific microbe and make an antibody against that. And that is what we're going to talk about in chapter 17. Which is the adaptive immunity, which will come in just a little bit. So good job. That's the first part of the immune system.